So I had to put this talk together quite quickly, so thanks to everyone who helped along the way. There are many of them. Many are in the audience. Ian Chalmers, Ian Roberts, Sarah Thomas is here, who did a lot of the analysis. Some are not in the audience, like Ben Goldacre, who unfortunately is away with sickness in the family. And particular thanks to John Williams. I'm going to talk partly about randomised trials. And John Williams in Cardiff was one of the first people to suggest we could do better trials using data. So this is the sort of thing I'm talking about. This is a 2 terabyte hard drive, and it's got 12%, random sample of 12% of the UK population's health data on it, their whole health record, primary care, secondary care, the whole lot. So those of you from the UK, 12% of you, your medical records are on here. They're encrypted and they're completely anonymised, and we have ethical and legal approval to use them for specified research questions. So I'll come back to that, but there it is. Have a think. Okay. I'm mainly going to talk about opportunities for research using data. So why is computerised electronic health records, why are they good, why are they important? I'm mainly going to talk about research. What can we do with them? We can do research that couldn't be done otherwise, we can do better research, and we can do cheaper research. I'm just going to show you a couple of examples. I first got interested in this area because of measles vaccine and autism. Many of you will remember this problem. And measles vaccine coverage fell in response to this scare. And we're still witnessing in the UK now, particularly in Wales, the results of that. There are a few studies undertaken at the time very rapidly, including one here at the school that we did, this one here. And here's a meta-analysis of those studies, all of which were based on anonymised electronic health records. The Danish study by Madsen used the whole population of Denmark, for example. We used medical records from several million people. And these studies could not have been done at all, and certainly could not have been done anything like as quickly without the use of anonymised records. Here's another study. I'm presenting this one. This is a study we did looking at whether infection triggers heart attack. And to do this study, because by definition you don't know who's going to get an infection, you don't know who's going to get a heart attack, we again had to use medical records of millions of people. And I think I can probably say, it's not proven, this is probably the cheapest New England Journal of Medicine paper ever. The British Heart, this was done entirely with a £76,000 grant from the British Heart Foundation, and they should be forever grateful to me. Here's another piece of observational research. This is looking at the effects of air pollution on heart attacks and whether air pollution can trigger heart attacks, and this has been quite controversial, and there's been really a failure to show an effect, even though everyone thinks it's there. And by using national data on over 80,000 people with heart attacks, linked to national environmental data, we could show that there was a triggering effect of particulate matter and nitrous oxide, but only in the first few hours. And we could only do this because we had national data and because we had accurate data on the timing of onset of heart attack. So this is about the quantity of the data, but also the accuracy of the data allowed us to do this. So that's observational research. I'm going to focus a little bit on why electronic health records are important, because I think they can help us do better trials, and this has received kind of relatively less focus. Now, we heard in the talk just before tea about difficulty with generalizability of trials. Randomized trials are often done in very atypical populations with different comorbidities and things, making them poor guides to clinical practice and policy. That's one problem. Another problem with trials is logistics. They're difficult to recruit to. Some people in this very room have done some fantastic large trials, but many people over many years have had difficulty recruiting into trials, and loss to follow-up is a big problem. And trials cost a lot of money. Can electronic health records help? Well, we've tried to push this idea that they can. This is a paper we put in the BMJ. And this is all about what should we be doing in the absence of evidence. And there's a query here. So if we go back to, we're lacking evidence about a question, what should we do? And it's all about the fact that we should randomise. Oh, it's not there. But what you can do, you can either randomise in the absence of evidence, or you can go and see one of these people. This is on Brighton Pier. This is a fortune teller, a gypsy fortune teller. And what's brilliant, if you focus in, corporate clients include GSK. I believe there are some people from GSK here. More terrifyingly, Deutsche Bank, who I believe are currently propping up the whole European economy. So, what do we do in the absence of evidence? You can either go there, but more importantly, I thought what I'm pushing, what you should do is randomise. Can we make it easier and better to randomise? I think we can by using, if we can use people's electronic data. So here's the story. We've got a clear absence of evidence. Is everyone happy to be randomised? And to be honest, I'm a clinician and I often quasi-randomise patients. I don't know what quite to do. I don't know what the evidence says. Some days I'll give this treatment, other days I'll give this. It happens in medical practice all the time. Can we formally randomise? If we could very rapidly and easily at the point of care, we could achieve follow-up entirely through electronic health records and rapidly accumulate a big evidence base. That's the basic idea. This is not easy. We're trying to do it. We're trying to implement it. It's not easy. I'm not showing you any fantastic results published in high-impact journals because we haven't got any yet. We're still trying to get it right. But here's a screen that pops up. This is a trial based in the General Practice Research Database in the UK. And here's a screen that can pop up. The computer identified that a patient's eligible for a trial. Here's a screen, and the clinician gets to choose from these boxes. This one's my favourite, do not disturb me for 2 hours. And here's a great one, patient not interested in ever participating in trials. So they've got to get out. But in theory, the computer identified someone with the right pattern of morbidities, about to get a possible right treatment that could be randomised. And they could be randomised as easily as that. And we could follow them up entirely, passively, through the use of electronic health records. That's the aim. And it's not just individual trials. I think clustered trials could be done much more easily using electronic health records. Randomising whole health service units is often done for organisational steps, but we could do more for therapeutic interventions too. So in the absence of evidence, is a health service unit reasonably happy to be randomised? Difficult to know who you'd ask. They can be randomised to different options. The follow-up of patients, the outcomes, can all be collected passively through electronic health records. And we could very quickly evaluate a very wide range of interventions using this sort of procedure. And you keep going and keep going and keep going until you've met your uncertainty. You've solved the uncertainty. So that's trials as well. Other reasons why access to electronic health records and electronic data are desirable. I think they provide extraordinary opportunities to improve public health and policy, not just research. We can count things better. I don't mean to dismiss public health as people who count things, but we can count things better. We can get disease burden, all sorts of things we can do. If you look in the UK at the moment, enormous fuss over the provision of paediatric cardiac surgery, and probably the best guide and the only guide we've really got as to which centres should and shouldn't be doing this sort of very high-risk surgery is coming from anonymised electronic health records. We've got extraordinary opportunities to improve clinician performance, not just do research, we can actually improve clinical care. Here's an example with this idea, and they're using this a lot in the States at the moment, with data-driven clinical decision support. This is in real time. So as clinicians are engaging with patients, data are being analysed about patients who are similar to the patient in front of the clinician, with similar problems, similar possible interventions, allowing patients and clinicians to see what's happened to similar patients in similar positions and what options they were given and what those outcomes were. And that's beginning to happen now. One last benefit, I think, of using electronic health records and having greater access is capitalising on this genomic revolution. So we've been talking that genetics is going to revolutionise healthcare for hundreds of years, as far as I can tell. I think the integration of genomic and other omic data in with clinical data to allow a more sort of stratified approach. I'd hesitate to say personalised, because I don't ever think this one single person is going to get the perfect medicine for them, but we can stratify people and make a much more personalised approach on groups. Can be done so we can get a better idea of what's the best decision for a patient. But I think the full benefits of that, they don't come from having the genomic data from one patient linked to their own morbidity. They come from the whole data set of the whole population. That's where we're going to get the benefits from, and the real benefits, not just the individual in front of the clinician who's making a decision. So, I think there are extraordinary opportunities to improve health through greater access to data, but I do have a caveat, a big caveat, is that a realistic approach is clearly needed. This isn't all straightforward. I completely agree with people who say that anonymity and confidentiality are crucial. I would say that malicious use of research data has been either rare or non-existent. We've seen very, very few, in fact, I can't think of any published examples where clinical data, medical data used for research has been maliciously sort of de-encrypted or de-anonymized. But we do need appropriate safeguards in place, but they do need to be proportional. So for completely anonymized data, such as on here, where about 20 or 30 of you lots of medical records are on here, we have good safeguards in place. Okay, so we have ethical and legal approval to use these data as bona fide researchers with good scientific questions, and we can use that data. In fact, to go through the hassle, if you wanted to go through the hassle of getting ethical approval and regulatory approval, getting the data, de-encrypting it, to actually identify someone on this data, I was chatting about it with some of the analysts I work with, and we worked out, really, you'd actually need to be the person you were looking for, because only you would know enough to be able to find yourself. You'd need to know dates and drugs and diagnoses to an exact degree to be able to find yourself. There will be, if someone really wanted to get access to your medical record, there will be far easier ways, I can tell you, than going through all that. Far, far easier ways. But we do need some caveat caution, and we do need safeguards. But I'll finish with saying that I do think there's a social responsibility on people to allow the use of their data. I mean, people reap the benefits all the time, whether this is because of the way we work out whether interventions work or what services are needed in a specific area. Whatever it is, people are whether measles vaccine is safe, whatever it is. And if people are going to reap the benefits, if people are going to be treated within health systems, I do think there's a social responsibility there for people to allow use of their data. That I do think most people take on and accept. So I'm not pushing for a totally open approach, publishing everyone's medical records on the web, but I'm saying that open access to data is important, open access to electronic health records is important, with safeguards, because the enormous benefits are there and because I think there is a responsibility on people to allow their use. That's it. Thank you.